Hello everyone. Assalamu alaikum wa rahmatullah. Today, inshallah, we will discuss very important topic and recent recall regarding management of CIN 3. And we will cover also the colposcopy if the patient will come to you in the clinic and you are here just to counsel her regarding the colposcopy and what will be done in this examination, what's expected, and you will ask her by the end to sign the consent. So it's obviously like two stations together, so it's not one. And both of them recent recalls, very important in the exam. And by the end of the task, I added here some extra slides regarding how about the cervical screening, the pathway, and also how you manage the patient while she's pregnant. If it's okay to offer conservative management of for CIN2 or not. So like extra slides, it might be a scenario in the exam in the future, and it's very, very important for you as a gynecologist to know about it, right? So let's go directly to the scenario. Yeah, here we go. So what I need today, I need two volunteers. One of them will present the colposcopy, how to counsel the patient about the colposcopy, and the other one will do counseling regarding CIN 3. So who will be the first to gather information or take history and then manage the patient? If the patient is here for the colposcopy, how to manage her, and then another one to do management of CIN 3. Any volunteer? Anyone? Hello guys, be brave, and I want one to present the case with me. Let's read the scenario first, and I may ask one of you to present the case with me, like sporadic. So you are the ST5 in the colposcopy clinic today, and you are about to see a patient. Her name is Anne Martin. She's 33 years old, and she's here today as she had her cervical screening showing positive results for the human papillomavirus. For sure, now cervical screening is done for human papillomavirus, and if it's positive, we will offer the cytology after that. And if the patient positive for the cytology, we will offer the colposcopy, which is already done for our patient today and showing CIN 3. The patient here to discuss the results, so you have to do the breaking bad news, tell her about this bad news, and then to counsel her regarding the management. You will be assessed in the following domains: information gathering, communication with the patient safety, applied clinical knowledge. Keep in mind that the management should be in the team or within a team, even if we don't have here communication with the colleagues, because as you can see, she's CIN 3. So, and she's already in the colposcopy clinic. If we are in the gynae clinic, at that time you will find communication with the colleagues, because you have to involve at that time the colposcopy team and also the laboratory team as well. So let's go backward here. Anyone to present, to just to ask the question. So let's take it like piece by piece. So anyone to gather the information? So I will choose from the people I know. Arifa? If you are not free, so it will be Kazi. Hello?
Hello?
Yes, Kazi.
Yeah.
Hello.
Yeah, I'm fine. How are you?
Yeah, I'm good. Okay, so let's start. Just I want from you to do the part of information gathering. Okay, Kazi?
Okay. Yeah.
Yeah. So let's go, even without timing. I will not put any timing for you.
Just give
Just
me 1 minute. I'll just relocate it. Just give me 1 minute. Yeah.
Okay, yeah, no problem. Take your
1
time.
minute. Yeah.
Sure.
Are you going to give me 2 minutes or I'll just immediately start?
Yeah, if you want to have the 2 minutes.
Yeah, just
Yeah.
give me 1 minute, okay? Because I was not ready actually. Okay.
Okay.
I'll just take the
1
history,
minute.
right? Okay, okay.
Just the history. Yes.
Okay, okay.
Okay.
Give me 1 minute only. Yeah. মা কথা বলো না।
Okay, no problem.
Yeah, let's start.
Okay, you can start.
Hello, I'm Dr. Kazi, one of the doctors in the Colposcopy clinic today. May I confirm your name and age, please?
Hi, doctor. I'm Anne Martin. I'm 33 years.
How do you like me to address you?
Anne is okay, doctor?
Okay, so Anne, I have gathered from your notes that you are here today to discuss about the camera testing through your frontal passage. Am I right?
Yes.
Okay. So do you have any specific concern or expectation from today's discussion?
No, doctor. Just I want to know the results and I want to know like what about the next step?
Okay. So I'm going to take the history about the colposcopy or this report, this CIN.
The report. Yeah.
Okay, this one. Okay. Okay. So I acknowledge your concern. I will discuss about the report and the further management plan. I will also connect with my consultant and the necessary referrals I will also do and give you the 24/7 contact number if you have any emergency. I'll also give the patient information leaflet and connect with the support group if you would like to. And before that, can I ask few more questions to know more about you?
Yes, doctor. Sure.
Okay. And can you tell me more about your problems?
So actually, doctor, what happened that when I had my cervical screening with the GP, I received a letter that it was positive for some sinister cells, as they told me, and I have to come here to this clinic to have the camera testing. And then they called me back and they said the results is out, and I have to come today to know the results. So this is the whole story.
Okay, I acknowledge your concern. Do you have any problem at this moment? Like as I can see that the tissue sample was taken. So after that, any problem?
No, doctor, just a spotting for 2 days, but after that, everything was okay.
No pain, right?
No, nothing like that.
Okay. Any other discharge?
No.
Any problem in the water work?
No, doctor.
Any bowel work problem?
No.
And some of my question might be intrusive or personal. Can I ask?
Yeah, sure, doctor. Go ahead.
Okay. Are you sexually active?
Yes.
Any problem with the sex?
No.
Any pain?
No.
Any bleeding after sex?
No.
Are you in a stable relationship?
Yes, doctor.
Okay, okay. Any change in the weight or appetite?
No.
Okay, tell me about your pregnancy. Have you ever been pregnant before?
Yes, doctor. I have 2 kids.
Okay. How was the mode of delivery?
It was by cesarean section.
Okay. Previously, were you in the regular follow-up with the cervical screening?
Sorry, doctor. I didn't get the question.
Cervical screening.
Yeah.
Did you follow previously also regularly?
Oh, yes, doctor. Yeah, I followed this regularly. It was all normal except the last one.
Okay, okay. Thank you. So in no other treatment before, right?
No.
Any contraception?
I'm using the barrier at sometimes. I'm not regular, to be honest, doctor.
Okay. Any medical condition?
No,
Any surgery?
no,
Are you using any medication?
no,
Any allergy?
no, doctor.
Any family history of concern? Clots or anything?
No,
What is your weight height ratio?
it's around 29.
What is your blood group and RH?
It's A positive.
Any reservation to blood and blood products?
No, I don't mind.
Okay. Do you smoke?
Yes,
Drink alcohol?
occasionally, doctor, over the weekends.
Pardon me asking, any recreational drugs?
No, nothing like that.
Okay. What do you do for living?
I'm a housewife at the moment.
Okay. I have support at home.
I'm well supported.
Over the past 4 weeks, are you feeling down, depressed, or hopeless?
No, doctor, just I'm a bit anxious and like worried about my results, and that's it. But I'm good, not too bad.
Okay. Thank you for sharing all this information. And do you want to add anything else?
No, doctor, thank you.
Okay, so and I can see that already the report is done, but if you allow me, with the presence of chaperone, with your permission, I'd like to just examine you. My nurse will check your observation, that is the pulse, blood pressure, temperature, and the saturation. I'll check your tummy, and quickly I'll just check that whether there is any features of infection. But I think that there could be report of swabs. So if it is not done, I may take that swab also. Is that okay for you?
Yeah, that's
Okay.
absolutely fine.
Okay, so now coming to the report, I can see that you are alone here today. Do you want anyone to accompany you?
No, doctor, please go ahead.
So, and I have some concerning news to discuss with you. Is that okay to continue?
Yes, doctor.
And I don't have a good news. So, the report was taken, the tissue sample was taken from the neck of the womb. It is showing that CIN3. Have you ever heard of it?
No, doctor, what this? Is it a cancer?
So, and it is not a cancer at this moment. Let me draw it for you. So, as you can see, so the sample was taken. This is your womb. This is the neck of the womb. The sample was taken from the neck of the womb, and it is showing the CIN3, meaning that the lining of the womb, the neck of the womb, it is just like the lining of our skin. So, it has several layers. So if it is coming up to the third layer, so this is, you can see the first layer, this is the second and the third. If it is coming up to the third layer, it is called the CIN3. At this moment, it is not cancer, but if it just progress after that, it may turn into the cancer, but it takes a long time to turn into the cancer. So we have the time to treat you properly. Am I clear so far?
Yes, very clear, doctor.
Okay. Do you want me to explain the management now?
Um, no, doctor, thank you. I will stop here, Kazi. If you
Okay.
want to discuss
Thank
the management, so we will go forward, but let's take it like part by part. So very well
you.
done. Your time, I told you that there is no time limit, but I want to see like your time management. So I put the time here like a secret. So you consumed 4 minutes 40 seconds. Still, it's very good timing. Colposcopy and CIN3 or CIN3, it's considered oncology. Usually with the oncology and urogyne, the history will be a little bit longer and it will take time. If it's around 4 minutes 30 seconds, it will be excellent in the exam because you will be able to finish on time, right? So very well done. Let's go to see if we have any missed point in your information gathering. I love from the start your introduction and agenda, giving me the information leaflets at the start. Very important point, guys, because if the time finished in the exam and you didn't mention the patient information leaflet, it's point very, very important, and it's crucial for the communication with the patient and patient safety as well. Giving the patient, even if you don't have written information, I mean in your practice in reality, so even you can advise the patient about leaflets online. Sometimes you are giving the patient, like, for example, to visit the RCOG website. We can put it like in the discharge letter just to have a look on like what's expected, for example, after laparoscopy. So we can put this like the RCOG website in the discharge letter if we will not be able to give the patient a copy at the moment, or even just to advise the patient verbal. Sometimes the patient will refuse to take hard copy for some reasons. Sometimes the patient gonna say, no, I don't like, for example, anyone at home to know that I was here or I have this problem. So right, no problem, respect her wishes and just advise her just to put in the search this topic like CIN3, and it will come to her like, and patient information leaflet for sure. And she can access many patient information leaflets here from different hospitals and trusts in UK. So it's a very important point, and you covered this, Kazi, very well done. And you started to gather the information. You started with open question. Again, I love from your performance that you asked about how is the patient after the colposcopy in terms of any pain, any bleeding. So it was excellent point from your side. So let's go and see the detailed feedback. So introduction agenda, introduce yourself. You are in the colposcopy clinic, setting the agenda. I've gone through your notes. You can use different ways, guys, here. I've gone through your notes, or I read your notes, or I have your notes here with me. And I understand that you are here today because you want to discuss your results and your management plan. Is that correct? Yes, doctor. So do you have any other concerns or expectations from this consultation today? No. So I will address all your concerns within few minutes. And before that, I'd like to ask you a few questions to know more about you. Is it okay? Yes. By the end of our consultation, I will provide you with some leaflets regarding what we will discuss today. I will set another appointment with my consultant. I will attach you to support group, and I will give you a contact number. It's 24/7 for any emergency. How does it sound, or is it okay? Yes. And then start to gather the information. We need to start with open question. And this open question here, tell me more about your problem. So the patient will start to tell her story, what happened. Like she had the colposcopy, she had, sorry, the cervical screening first, and it was positive. They invited her to attend the colposcopy clinic. They got this tissue sample, and then they called her back that the results is out, and they want her to attend. So this is the whole story. Start to ask questions first about the colposcopy, any pain, any bleeding, any discharge after the colposcopy. Then ask her about sexual history. The problem here that sometimes the patient will have multiple partners. So how to ask about the multiple partners to rule out the risk at that time. So ask her if she's in a stable relationship or not. Some of the candidates will ask directly, like, do you have multiple partners? It will be something a little bit rude for the patient to ask her such a question. So ask her first, are you in a stable relationship? Yes, doctor. You have a stable partner? Yes. For how long? Like 3, 4, 5 years. So it's like a stable relationship at that time. If not, so how many partners in the last 6 months? If it's 3 or more, this is multiple sexual partners. Ask her about any history of sexually shared infections before. Ask her about her period, when was the last period, and how about the regularity, the last menstrual period, to adjust the timing of the colposcopy and the treatment at that time. Then we need to ask her about her personal history, smoking or social habits, smoking, alcohol, recreational drugs. This patient is a smoker, so we will stop here. Usually my advice in some situations like smoking, alcohol, or the RH lady, like if she's RH negative and she's pregnant, counsel immediately. Because if you will leave it to the management, usually most of the candidates will forget. Even me, I will forget. So what we can do here, so stop and let the patient know about the harm of smoking regarding the general health and the cervix itself. So smoking will make the human papilloma virus to flourish. And also it will affect the healing after the colposcopy because we will do cutting of the neck of the womb. So advise her about smoking cessation program clinics. And if she's happy to be referred, arrange a referral today for her. BMI, it's important, just part of the here. It will not have any like implication on the management, but it's very, very important to know if this patient is with high BMI, obese or not. Rule out any allergy, because we need to give some medications sometimes, like the local or the lidocaine or numbing material, and also the substance we are using in the colposcopy. Sometimes the patient will be allergic to it, like acetic acid or iodine. If the patient cannot accept blood or not, it's plus or minus here, because usually with the colposcopy, the patient will not bleed to that much, to the level that she need or she will require blood transfusion. Cervical screening here, like what you asked, Kazi, and very well done. If this patient was regular before the last time or not, any treatment received so far or not. Like if, for example, she had same condition last year and she received the treatment. So we need to be sure that this cervix, it's not a scarred cervix. Very important point. Double check the contraception, and obstetric history also important, just to rule out if this patient has cesarean section and adhesions. And gynecology, it's like the discharge, if this patient has any problem like a discharge. Sometimes we can remove some questions, like if you feel the gynecology it's like not important, so at that time you can remove. The contraception important just to avoid the unwanted and unplanned pregnancy, and also to advise her after that, especially if she's younger in age and if she's not in a stable relationship, to advise her regarding using a barrier to guard against the sexually shared infections. Medical, surgical, family, mental, and social. Just continue your template and then just say, thank you for sharing this information with me. Do you want to add anything? And then move forward in the examination. Again, examination here plus or minus. So as you mentioned, Kazi, you justified your answer. You said, what do you want to do? So it's accepted. If you will tell the patient just examination and that's it, in the exam, it will not be accepted, guys. So now the last word from the RCOG, if you want to examine a patient, please justify what do you want to examine and why. Here, for me, it's plus or minus. I can jump and just ignore the examination because I have a report and I will give the patient the bad news, and that's it. For the swabs, it should be taken before the colposcopy. So you can double check on the system, ask the patient if she had swabs done or not, because usually we are doing this before the colposcopy. So it's already done for the patient. If not done, so you can take the swabs like what you mentioned, Kazi, and don't forget in presence of chaperone after permission. For the people who will go to the online exam, because now we have in some countries online exams till for May 2025. So since this is an online consultation, so deal as you are doing, because a lot of time we can speak with the patient over the phone, right? Just to tell her about a result, or she has to come back to us and so on. So since this is an online consultation, when I will meet you or when you will come to the hospital, I'd like to offer you examination in presence of chaperone after your permission. So this is the answer of if I'm doing online exam, how to counsel or how to examine the patient online. Okay, guys, so this is the answer of this question, because nowadays, because of the online exam for May, I received these questions from many candidates, right? So this is how you will answer this. Now, this scenario, when I made this model answer, it was only for management of CIN3. So I put extra slides for the colposcopy. This scenario, it came in May 2024. Okay, guys? 2024. And then I put here in the explanation slides about the colposcopy first. Check first the knowledge of this patient about the colposcopy, right? And I told my candidate, and also in case of the RCOG, will change the scenario and it will be, for example, abnormal cervical screening and the patient here to be counseled about the colposcopy. And this has happened in November 2024. So the patient is here to counsel her regarding the colposcopy. So how to counsel the patient? So now coming, I will speak like I'm speaking to the patient. Her name is Anne, right? So now Anne, coming to your concern. This is the second scenario, guys. So we are now touching the second scenario, which came in November, and it's all about the colposcopy, not about the management of CIN, okay? So now coming to your concern, Anne. The colposcopy, it's like a test to take a closer look at your cervix. The cervix, it's like the neck of the womb. It's like the opening of your womb inside the vagina. Am I clear so far? Yes, doctor. Usually, It's done if we have any problem with the cervical screening, like having abnormal cells. Usually now, not usually, like in all cervical screening now, we are testing first the human papilloma. So before 2020, it was cytology first and then human papilloma. Now it's the reverse. Human papilloma first, and then if it's positive human papilloma, from the same sample, we will not call the patient again. We will see the cytology. If the cytology showing sinister cells, we will call the patient for the colposcopy. Right? Coming back to the counseling. So during colposcopy, what will happen? We will put smooth tube-shaped tool, which we name the speculum. You know the speculum which we used in the cervical screening? Yes, doctor. So it's the same. Gently, it will be placed inside your vagina to open it up. It shouldn't be any pain. Sometimes with the speculum, you might feel some discomfort. So at that time, you can ask the doctor to stop. Then we are using a microscope, and this microscope will be outside your body, so it will not be inside. It just to give us like a magnified picture of your neck of the womb to have like a closer look. And then after that, we will take a small sample from the neck of the womb. We might need to apply some fluids or liquids like acetic acid and iodine. This fluids, it will make some changes if we have any sinister cells or any abnormal growth. So it will be colored with a different color. And we will take the tissue sample from it. Am I clear so far? Yes, doctor. Do you have any questions? No. So this colposcopy, it's like a very simple procedure. However, with taking the sample, you might experience some pain, bleeding, infection, but we will be like careful taking the sample. And at that time, you have to come back to us. We will give you a 24/7 contact number. Are you still following me? Yes, doctor. What to be done before the colposcopy? For 24 hours before the colposcopy, please do not have any penetrative sex. Do not use any products inside your vagina like the tampons, creams, medications, or any medicines. You might have some minor bleeding. It can be like expected, but if it's severe, please come back to us. If you have any coil in place, like the copper coil or the hormonal coil, usually no need to be taken out. Just tell the person or the doctor who will do the colposcopy that I have this coil in place. Are you still following me? Yes, doctor. So this is how you will counsel the patient regarding the events. This slide, I took it like screenshot from one of the leaflets regarding the colposcopy. I love it in that way. So that's why I didn't want to disturb it. So tell the patient what happens and what it might feel like, what's expected, what the patient will feel. So putting the speculum, which is a smooth tube-shaped tool, gently placed inside the vagina, and then we will use the microscope from outside. So this is the speculum. What will happen? Put the speculum. What the patient will feel, a little uncomfortable, but you shouldn't be in any pain. Usually use these words with the patient. When you will put a speculum, tell the patient it shouldn't be any pain. However, you might be a little bit with feeling little bit discomfort. The second thing will happen. The doctor or the nurse will put some liquids on the cervix or the neck of the womb. These liquids will help them to see any abnormal cells. So liquids, we will put liquids. What about the feeling of the patient? You might feel tingling or stinging sensation, right? So tingling or stinging. Then a small tissue sample will be taken. It's just around the pen head size. Do you know the pen like this? So this is the size of the sample. It will be taken. This is what will happen. How about the feeling of the patient? You might feel some or mild pinching or scratching. So speculum, little uncomfortable. Liquid, tingling, stinging, tissue sample, pinching or scratching. Use these words in your counseling. It will be like you like impressive to the examiner, because it's very, very important, guys, to tell the patient about every single thing that might happen. Here in UK, they are different in this point. We have to tell the patient, even if like very rare thing that might happen, we have to tell the patient about it, right? So this slide is very, very important in your counseling. So this is counseling of the colposcopy. It's extra slides here for CIN3 because already the patient, she had the colposcopy, but she will have it again for the management options. So now coming to the management options. If you want to continue from this point, Kazi, as you like. If you want to continue the management,
Yeah, okay.
yeah, sure, go ahead. I will put again a timer to see how many minutes you're gonna take in the management, okay? Kazi,
Yeah.
please unmute yourself.
Yeah. Am I
Oh,
audible?
yes, now, yes,
Okay. Should I start now?
yes, please.
Okay. So, and coming to the management plan, so your management, it will be usually the management will be done in an outdoor basis. So usually you will not be admitted. It will be like day case procedure. It will be a shared care. So you and also your partner will be involved in the care. A group of expert team will be involved, including the special doctor, we call it colposcopist, the gynecologist, consultant gynecologist will be also involved. And generally the pain medicine, that is the anesthetist doctor is not needed, but if you choose to be put in sleep, that time anesthetist may also be involved. Specialized nurse and the GP will be involved in your care. Am I clear?
Yes, very clear.
Okay. So coming to the options, so we have three options. One is the conservative, another is the large loop excision. I'm coming into it in a details, and the cone biopsy. So conservative, as you have this problem, the CIN3, it is not considered safe. However, we may have some lifestyle modification. So as you are a smoker, so I'll connect with the NHS stop smoking service if you'd like to stop the smoking, because it will help you to prevent it proceed to further and the further follow up also. Am I clear?
Yes, doctor.
Generally, the management which is recommended, that is the large loop excision. So let me draw it for you. This is the neck of the womb, as you can see. So when the colposcopy is done, it is as like the similar procedure. So we will need your consent. It will be like informed and written consent. Another thing is the colposcopist will be there, and also presence of chaperone. After putting you in that positioning, that is we call it lithotomy position, as during the colposcopy was done, the same same positioning, what we will do, we will provide the numbing injection using the similar type of like dental or the tooth extraction type of thing. So similar injection will be provided to numb the area, and then we will use a special instrument, we call it wire loop. It will be heated using the electricity, but we will put a special safety pad not to burn yourself, and then we will remove the abnormal area of this neck of the wound. Am I clear, Anne?
Yes, very clear, doctor. And is it safe, doctor, to have this cutting?
Yeah, so generally it is considered safe, but there are certain risk of having slight bleeding during the procedure, injury to the surrounding structure like frontal passage, very rarely injury to the water bag, very rarely, and also the back passage, and your area, that is the vulval area. But we will be very gentle, and the expert colposcopist will do this. Don't worry about that. After the procedure, may have some spotting, but if you have severe bleeding, so I'll give the 24/7 contact number to let us know, and little bit pain, we will give the pain relief for that after including the allergy.
Mhm.
Usually no infection, but if you have any features of infection, we will also provide you the antibiotic. Another thing is, after that, we will also advise you not to have penetrative sex for usually 6 weeks, and do not use any tampons or any vaginal creams, because it may increase the risk of the infection, because there will be slight spotting there. So this is the advice we want to give you. Am I clear so far?
Yes, very clear, doctor.
Yeah. Another thing is the for the long term, there may have, if you want to be pregnant. So may I know that what is your planning for the future pregnancy?
Yeah, maybe I need another baby. So I was planning to have three or four, doctor.
Okay, so let me tell you that in the future pregnancy, there is risk of having late miscarriage. So after the first 3 months of the pregnancy, another is the risk of having preterm birth or cervix, that is the neck of the womb, may be stenosed. But don't worry, you will be under proper follow-up. So whenever you are pregnant, we will do the internal scan. We call it transvaginal scan to check that your neck of the womb is shorter. If it is shorter, we will do first time the scan around 18 to 22 weeks. If it is more shorter than the normal, then we may put the stitch, or sometimes there is using of the medication called progesterone, or there is pessary also. Okay, so your specialist doctor will discuss. So that is the special clinic, we call it preterm prevention clinic. Am I clear so far?
Yes, very clear.
Your follow-up will be done in, yeah, anything you are asking?
No, go ahead, doctor, please.
Yeah, so after doing this tissue sample, we will test is under the tissue specialist doctor will test it. And if we find any other abnormal things, we will discuss it you. Your appointment will be after 6 weeks. And after 6 months, there will be another test. We call it test of cure. Am I clear so far?
Yeah, very
Any
clear.
other question?
So any other options, doctor, I have?
Yeah, so another option is also there, that is the cone biopsy, where a more tissue will be taken. That's why usually local numbing agent is not enough. We may need to put you in sleep. So that's why anesthetist doctor may be involved in the care. We call it cone biopsy.
Okay.
Okay,
All right.
that is the another option. But generally, the recommended option is the large loop excision of the transformation zone, as I mentioned.
Okay. All
Okay,
right. Yeah.
any more question?
No, doctor, thank you.
Okay, so and I will provide you the patient information leaflet and connect you with the support group. If you have any question, just let us know. Okay.
Okay, yeah. Thank you,
Oh,
doctor.
okay. Thank you so much.
Okay, very well done, Kazi. You consumed 6 minutes here in the management, so we need to make it a little bit short and also to make the information gathering shorter, so you will fit in the 10 minutes, right? But very well done. I love your performance. Thank you so much. Involving the team, explaining who is the team, and also the options, drawing for the patient. It was very nice from your side because you will enhance your marks here. Um, you give her the three options and test of cure, one of the safety points after lids procedure. You give her the risk as well and what to be done after having this cutting. Even you touch the point of the next pregnancy in a very nice way. You can make it a bit shorter so you can save the time here. Next time when you will be pregnant, you will be liable to have miscarriage or delivery before the time. So please just let your midwife knows about that. You will be a high risk pregnancy at that time and you'll be under the consultant care. And at that time, they will offer you another test to see like the length of the neck of the womb, right? Instead of giving like extra details with the timing. I know it's like it will take around 30 seconds, but it's very important. So let's go back. So here, I don't have any comments for you, Kazi. I'm very proud of you. Thank you so much. You did a great job here, and it's totally passing station for you,
Thank
right?
you so much, Manima.
You're welcome, Kazi. Let's go backward as we are counseling the patient now, and we will do the breaking bad news, explaining the CIN3 and then the management options, all right? So I will speak like I'm speaking to the patient, doing the breaking bad news, explaining CIN3 for her. So now I'm coming to your concern. I have here your report with me. Do you have someone to be with you, Anne? Because I have some concerning news. No, doctor. So I'm really sorry, Anne. I think I don't have a good news for you. I have here your report with me after confirmation of your name, age, and NHS number. I believe this report belongs to you. It's showing that you have what we named CIN3. Have you heard about this before? No, doctor. So CIN3, simply it's cervical intraepithelial neoplasia, and it's stage 3. So from the word cervical, it's the neck of the womb. Intraepithelial, this is the covering of the neck of the womb. Neoplasia, it means sinister cell. So let me draw here for you. You know that the covering of the neck of the womb, it's like our skin. So we have here the upper layer and the lower layer, right? So if we will come to the upper layer, this, and we will make it 3 parts. So if the sinister cells will be here in the upper 1/3, this is CIN1. If the sinister cells will be here as well, so it's upper 2/3, so it's CIN2. 2, if the sinister cells in the whole depth of the upper layer, so it's CIN 3. And then check understanding. Am I clear so far? Yes, doctor. Just one point here when you spoke about this, Kazi, just to correct this for you. You mentioned that, just one second, I put it here in my, yeah. So you mentioned that the covering is 3 layers and now we have 3 layers affected. No, keep it like the covering is 2 parts, and in this part, the upper part, we can make it like 3 layers, right? So it's all in the upper part. If it will invade more, like you mentioned, so it will be cervical cancer at this time. This is how to explain. If no time in the exam, guys, don't bother yourself with the stages like CIN 1, 2, 2 or 3. Just say it's sinister cells in the covering of the neck of the womb. Okay? I love this explanation, like VIN. It's again sinister cells in the upper part of the skin covering your private area. So from the name, we can explain to the patient. Now coming to your management. Shall I proceed? Yes. So your management will be with a group of expert team, including my consultant, specialized nurse, and also the consultant in the colposcopy clinic, and the laboratory team who will examine the tissue which we will take after this cutting of the neck of the womb. We do have 3 options for you, and either conservative or large loop excision of the transformation zone, what we name medically LIDS procedure, or a cone biopsy. For the conservative, I'm really sorry, Anne, it's not suitable in your condition. It's only for CIN1 because now it's the whole depth, as I showed here you, it's the whole depth of the upper layer. If it will invade more, it will be cervical cancer. So we don't want to wait and see. We need to take an action. Is it okay? Yes, doctor. The second option is the large loop excision, and actually this is the recommended management option. So it's the most common way to remove the abnormal cells. What we are doing, we will do colposcopy again, like what you had last time, and we will use a heated loop of wire, and we will remove area of tissue. It's about the size of the fingernail. Am I clear so far? Yes, doctor. This procedure will take around 15 minutes to be done. If you will feel any discomfort during the procedure, so you might need more local anesthetic. What we are doing before this cutting, we will give you a painkiller, and also we can numb the area around the neck of the womb. By any chance, if you start to be discomfort or having more pain, we can give more numbing material around the neck of the womb. Are you still following me? Yes, doctor. If you have any coil in place, no need to just to have it out, but just let the doctor or the nurse know, so they will try not to cut the thread. But again, just to reassure you, if by any chance this it's like an incident or this happened, like cutting of the threads, so don't worry. When you need to remove the coil, at that time we can have a camera testing and to be removed easily. Are you still following me? Yes. This cutting of the neck of the womb considered safe. However, it can cause some problems like bleeding, infection, injury of any structure around the area, like injury of the water pipe, injury of the vagina itself, the vaginal walls. But it's considered safe. We will be sure that we will not have any complication. Sometimes the patient will ask to have it on general anesthesia. And yes, you can agree, like, yes, we can do it, like to put you on sleep, and we can do cutting of the neck of the womb if the patient refusing completely the local anesthesia. Coming to the third option, which is a cone biopsy, usually we are using this if we are suspecting more aggressive disease. It's usually, guys, used in CIN3, but if it's like occupying a big area of the cervix, or in glandular neoplasia, at the time we have to offer the cone biopsy. Here we are removing a cone-shaped section of the tissue of the cervix. We have to put the patient on sleep. It's better than the local anesthesia. And at the time, the patient has to spend the night to sleep over in the hospital. The LIDS procedure, the patient will go home after, right? What we need to do after having this cutting of the neck of the womb, what's after colposcopy? So you can often go home same day. After colposcopy, you might experience some mild pain. It will be like period-like pain, but it will be controlled by simple painkiller like paracetamol. However, if you have severe pain, you have to come back to us. It's expected again to have some bleeding and discharge. However, it should just to be like for few days. Some ladies, it will continue up to 4 weeks because we have a raw area. But if it's severe bleeding, so at that time, you have to come back to the hospital. If the patient have any or has any bleeding, discharge, pain, we need to advise her, do not have any penetrative sexual intercourse, and usually this is after any colposcopy and cutting because we have a raw area. The risk of infection will be higher, risk of bleeding at that time, and this will be for 4 weeks. Do not use tampons, any menstrual cups, and use the pads instead. Avoid some activities like trampolining, you know, the trampoline, or vigorous exercise. This will increase the breathing, and also it will increase the risk of bleeding at that time. So this is what we need from the patient after lids or cone biopsy. We have a test, what we name test of cure. This will be done after 6 months. Advise the patient not to miss this test of cure. We will have another screening for the neck of the womb to see if still we have any abnormal cells or not. So this is how you will counsel our patients. So now we covered 2 scenarios, and both scenarios recent in the exam. Coming to the extra slides, and when you will find this star and the word extra, it's extra slides. How about the pathway? Now, after the recent update in 2020, in this guideline, we have the 2 weeks pathway or 18 weeks. So if we are suspecting invasion or high-grade dyskaryosis, like moderate or severe, or glandular neoplasia, borderline changes, please refer this patient through the 2 weeks pathway. If you are thinking that, or not thinking, if you have the results like it's low-grade dyskaryosis, borderline changes, or persistent human papilloma virus, please, or persistent inadequate samples, please refer the patient through the 18 weeks pathway. At least 99% of the patients must be offered colposcopy within 6 weeks. So even with this 18 weeks, you'll find the patient seen within 6 weeks. Another extra slide. How about the depth of the excision? So we are doing excision. So in type 1, CIN1, you are removing a depth like around 7 millimeter or more. In CIN2, it's 10 to 15. CIN3, it's 15 to 25. And it does make sense here, isn't it, guys? Because CIN1, it means that it's just the upper layer of the, like upper 1/3 of the upper layer covering the neck of the womb. And here it's the upper 2/3, and here it's the whole upper layer, right? So CIN1, 7 millimeter, CIN2, 10 to 15, CIN3, 15 to 25. Another extra slide. And usually I'm advising my candidate why I put this here. It's like a complicated chart, even it was like annoying all of us in part 2. But because I know that you will go like, you know, subconsciously, you will go and search and to find the cervical screening and how to go through this chart. So I put it here, so no need to go and check the guideline. Human papilloma virus testing, if it's positive, so we will check the cytology in the same sample. If it's abnormal, go for colposcopy, easiest part. If it's negative, routine recall. Routine means every 3 years in young ladies, 5 years in the old ladies. And why this? Why this time frame? Because it's more common in young age, the cervical cancer. If the cytology negative after human papilloma positive, this is the tricky part. Rescreen in 12 months according to the human papilloma. Positive, go this way. Negative, routine recall. And if it's positive, cytology abnormal, go for colposcopy. Negative, rescreen in 12 months. Again, after rescreening, here, this is the first time. Okay, guys, human papilloma positive. And this is the second time, human papilloma positive. And here is the third time to have human papilloma positive. So wherever the cytology, is it negative, inadequate, abnormal, go for colposcopy. Why? Because we have 3 samples in 2 years. This is the start, and then this is after 1 year, after 2nd year, still the patient positive for human papilloma. So please, this patient for colposcopy. A second slide, when we will offer colposcopy, what is expected? To have inadequate sample or to have adequate sample. If we have adequate sample showing abnormality CIN1, 2 or 3, manage accordingly. If it's CIN1, 2 or 3 or glandular. But if we have no CIN on biopsy, no colposcopic impression of CIN, like abnormal blood vessels, like abnormal features, at that time, check the human papilloma virus. It's positive. How about cytology? Low-grade cytology? Good. Recall in 36. Not routine recall. Please, not routine. Why? Because we have in the routine 5 years in the old ladies, right? So at that time, or in like the elderly people. So at that time, she's like on cervical screening every 5 years. But when she will be here, you will call her back after 3 years. You got what is the difference and why it's in 36 months, not routine? If we don't have any impression of CIN, but high grade or borderline cytology, discussion in the MDT within 2 months. Do you remember? It was a very famous question in part 2, this point. Coming to the inadequate examination. If the human papilloma positive cytology low grade, at the time, repeat colposcopy in 12 months. At the time, if it's still inadequate, please offer lids. If it's inadequate, but the patient high-grade cytology or borderline, offer lids from the start. This is how you're going to manage the colposcopy. Coming to this point, if it's adequate, showing CIN, what to do? Next slide. Here we go. If it's abnormal and we have CIN1 or CIN2 or 3 or CGIN, which is glandular neoplasia, what to do? I will split this algorithm. I need from here CIN1, 2, and 3 only, right? CIN1, and usually it will not come in the exam because here we will not offer treatment. It's mainly conservative in all hospitals here in UK. They will not offer treatment for CIN1, right? So recall in 12 months and check the human papilloma. If it's negative, recall in 36. If it's positive, check the cytology. Cytology abnormal, refer to colposcopy, right? Cytology negative, recall in 12 months. Again, check human papilloma. If it's negative, recall in 36. If human papilloma positive, cytology abnormal, this is the easiest point, colposcopy. But if cytology negative, recall in 36 months. And why? It doesn't make any sense here, to be honest, but because here human papilloma virus present and no changes, cytology negative. So it's there, but it didn't make any changes. So recall in 36 months. Coming to our scenario, CIN2 or 3, you need to offer a treatment. We can offer conservative CIN3, no. CIN2, we might think about it, and I will show you another extra slide. In case of in the exam, you have CIN2, and you will counsel this patient about lids, and then she will ask you, is it okay, doctor, to have conservative? How about your answer, yes or no? So yes, but we have some criteria to fulfill, right? So CIN2, you will offer treatment, or 3. Take care here, it's like more than or equal CIN2, so it means 2 and 3. And then test to cure in 6 months. If human papilloma negative, good, recall in 36. Human papilloma positive, we will not look at the cytology. Whatever the cytology, negative, inadequate, abnormal, please refer to a colposcopy. Why? Because here it means that she was CIN2 or 3. You offer treatment, she's still positive. Okay, guys, we will not wait because it means that this human papilloma virus will cause another changes and we need to offer her a colposcopy at that time. Let's go to the next slide. How about CIN2 and the conservative management? We can do it or not? Yes, but some criteria. Number 1, the examination should be adequate. ruling out any CIN3. So no CIN3 in the sample. By the way, sometimes the colposcopy or the tissue sample back to us as CIN2 and 3 together. I faced like a lot of patients like this, CIN2, 3 together. So you have to be sure that the examination was adequate and CIN3 wasn't there. Rule out CIN3. Number 2, no more than 2 quadrants of the cervix. So if this is the cervix and you put the acetic acid, you put this an iodine, and you notice the changes. So the lesion which you notice not occupying more than 2 quadrants. For example, it's here and in this area. So at that time, not more than 2 quadrants, okay, we can apply the conservative. Number 3, the MDT will agree about the conservative management here. Number 4, the patient is happy and agree to come every 6 months for cervical screening, no, for colposcopy examination. All right? And this will include repeat cervical sampling, repeat biopsy, not only colposcopy. So you have to tell the patient that you will come every 6 months for colposcopy examination plus sampling and biopsy. Is it okay or not? So 4 criteria here, guys. If we miss one criterion, we cannot apply the conservative in CIN2. So colposcopic examination should be adequate, ruling out CIN3, not more than 2 quadrants affected. Number 3, MDT agree, reviewed by the MDT and agreed that this patient can go with the conservative. Number 4, the patient happy and agree to come every 6 months for not only examination, no examination, sampling and biopsy, right? So this is the conservative management in CIN2. Coming to the cervical screening during pregnancy. So do you have any questions before we are like almost by the end? But do you have any questions? I know it's like a lot of information, but it's very, very important to cover all of this, not for the exam itself, for yourself, and in case of the RCOG will change anything in the scenario, right? Any questions? Okay, thank you. So cervical screening during pregnancy. If any patient has been called for routine screening and she's pregnant, we will defer this appointment. Cancel, reschedule 12 weeks after pregnancy, postpartum or postnatal. If any patient already referred with abnormal screening, so now she has abnormal screening. So colposcopy in the late first trimester, early second trimester, unless we have any clinical contraindication like patient with bleeding, with any problem. But any patient with abnormal screening test, we shouldn't wait, we shouldn't cancel or reschedule at that time. If we have previous colposcopy and it was abnormal and the patient now is pregnant, colposcopy should not be delayed because we have abnormal colposcopy. Another scenario, any patient seen early in the pregnancy, in early like first trimester, may require further assessment in late second trimester. Like here, she had abnormal screening and you offered her in the first trimester, early in the first trimester, and she needs extra assessment. You can do this by the end of second trimester, late second trimester. But if we have CIN2 or 3 suspected, repeat the colposcopy at the end of second trimester to be sure. If we are beyond this point, beyond the second trimester, please reschedule the patient to be 3 months or 12 weeks after delivery, following the delivery. Okay, guys, so different scenarios here during the pregnancy. Is it routine? Cancel, reschedule. The test should be deferred. If the patient already referred with abnormal screening, don't cancel or don't reschedule colposcopy. Do it late first trimester, early second. If the patient was assessed early in the first trimester and she needs another assessment, do it by the end of second trimester. If the colposcopy abnormal at that time and the patient now is pregnant, don't reschedule the second colposcopy. So she had previous colposcopy with showing abnormality. Do it the colposcopy, do not delay it, right? Do not delay. CIN2 or 3, examine again by the end of second trimester. If beyond this point you are in third trimester, please reschedule the appointment after the delivery, 3 months or 12 weeks after the delivery. So this is the different scenarios during the pregnancy. Do you have any questions? Okay. All right, guys. So that's all for today. Thank you so much for your attendance. What I will do with you, with all of you guys, I will try to arrange one meeting weekly till the exam, inshallah, just to cover the tricky scenarios. For example, like one topic with 2-3 different scenarios in the exam, recent recall, and it's like hard to manage how to answer the questions in the exam. So I will try to do it like on weekly basis. I will arrange my schedule for this week and I will post on the group the next timing. If you have like, if you can suggest like one topic you feel it's difficult, you can do that. Just drop a message on the group and I will try to arrange the next meeting on that topic. Okay, guys, thank you so much for your nice attendance and nice performance. Thank you so much, Kazi. Thank you so much, Isra. Thank you so much, Rimas. Thank you so much, Hala. And the last one, Zoom user, thank you so much for your attendance. Okay, guys. Thank you so much. Assalamu alaikum wa rahmatullah.